Prynawn da pawb, good afternoon everyone. I hope you all enjoyed this morning's sessions. I certainly took a lot from hearing from our colleagues in Scotland, in England and across Europe. I've already learned a lot, I hope you have too. I'm really excited to continue our fantastic agenda into this afternoon and explore some more issues that I know are really important to you and your services. Something that's come up a number of times today has been about access to mental health services, and we know that continues to be a challenge for lots of projects, not just here in Wales, but across the UK and internationally. We're really pleased to be being joined by some colleagues from Greater Manchester today. We're going to hear about how the Housing First project in Greater Manchester has been working with their local mental health trust to try and make sure that the people using Housing First services have got access to the mental health support that they need. I'm sure you'll all have lots of questions, so please feel free to put those in the Q&A section so that we can get the most out of this session. But without further ado, I'm going to first introduce Martine Whitehead, who is so kindly giving up her time today to share her perspective from Greater Manchester Housing First. Martine, welcome, croeso, to the conference, and we're really looking forward to hearing what you've got to say. Thank you.
Oh, lovely. Thank you so much for that, Katie, and thank you for inviting us here today. So I'm going to start by giving some background to you as to how the health offer started and I guess how it's evolved over time. So here in Greater Manchester, people may be aware, but we were lucky enough to have a 3-year social impact bond, which was around supporting entrenched rough sleepers in a housing-led approach into their own accommodation. And that was a really successful programme. And there was a number of key findings from that and lots of learning. One of the things was that there was a huge gap into access into substance misuse services and mental health services for people that have experienced entrenched homelessness. Also that people who had experienced entrenched homelessness had a real lack of trust in systems, didn't want to engage just due to past experiences. The SIB also found that pathways were a problem. Either in some cases the right pathway didn't exist for the cohort of people we were working with, or if they were the pathways, then potentially they could be really, really difficult to navigate. So when the opportunity came up to bid for the Greater Manchester Housing First pilot, we really wanted to incorporate the key learning into the partnership from day one. It was just such a great opportunity to do things differently. And as we all know who work within Housing First, it absolutely is a partnership approach and should be, and health is a key partner. So with all of that learning with us, we approached Greater Manchester Health and we worked together to think about what that offer could be, taking into account the feedback that we had from frontline practitioners into barriers that they'd had supporting people to navigate the systems. And also, of course, hearing the stories from people with lived experience who had experienced firsthand some of the barriers of entering into treatment systems. So with that in mind, the key aims for the partnership initially were to identify barriers into access to health and drive system change, to develop an integrated care pathway for people on the programme within the partnership, to be able to support people into navigating pathways into treatment when the time was right for them, and also to get a really embedded approach to reduce avoidable presentations to statutory services and emergency hospital admissions. We all know that can, not only cause a lot of trauma for people, but a preventative approach is far better. And it was really, really important as well for us to ensure that that health offer was very trauma informed. It was based upon building relationships with people on the programme, building that trust up again and providing that base to do real advocacy for access into pathways for people. So our partnership approach, we've got 4 zones in Greater Manchester Housing First of delivery teams, and we have 1 dual diagnosis practitioner who sits within each delivery zone. And that was so important to us because we didn't want the dual diagnosis health offer to be a bolt-on or an add-on. We wanted it to be really, really embedded within the delivery teams, and that's worked incredibly well. Greater Manchester Mental Health also sit on our programme steering board, and they take the thematic lead for health on the steering board, which again is great because we're able to take real issues, real cases, real themes, and get some expert advice on how to overcome those from the programme steering board. The partnership approach is really flexible, and that's so important because what we started out with and what we thought we needed from day one of the partnership is incredibly different from where we are now and what we've got. And, with that in mind, it's important not to have contracts or service level agreements that are too rigid because we've just had this approach where we've learned and shaped things together as we've gone along. One of the key things in the partnership approach is upskilling the partnership and beyond. So there's a lot of training and awareness provided not only to our Housing First workers and delivery teams, but we also offer that offer to the rough sleep teams, to the local authorities across Greater Manchester, with a view, that this is about raising awareness across the whole of Greater Manchester when working with people who've experienced entrenched homelessness and lots of trauma. And one thing that's really important to us in our partnership approach is about being brave and driving change. We're not frightened to challenge things. And we've also been very lucky, I guess, that we've been able to do some pilots within the pilot where we've been able to try doing things differently and evidence that those things have worked. And that's been able to drive change across Greater Manchester and improve practice on the ground. We're now going to show a short video that's of one of our lovely dual diagnosis practitioners, Gill, who's explaining a little bit more about her role within the programme.
Hi, so my name is Gill Heaton. I'm a dual diagnosis practitioner. I work for Greater Manchester Mental Health NHS Trust, obviously for Housing First. My role is to obviously support the Housing First support workers, and we do that in a variety of ways. We might obviously offer some training, some clinical support. So that could be obviously doing assessments, sort of brief interventions. It could be liaising with different services. So it's a whole bunch of stuff that we can advise and support to help the service users. Greater Manchester NHS Foundation Trust it has an inpatient setting and also community services which cover the whole of Greater Manchester. That includes mental health and substance misuse services. Dual diagnosis is a term that's used for somebody that's got dual conditions. So in this case, obviously, it's mental health and substance misuse. And we tend to deal with both those issues at the same time. People with dual diagnosis, the main issues that they kind of face is firstly stigma. They also distrust a lot of services with negative experiences that they have had in the past. And that might be that services have basically told them, e.g., mental health, please go and sort your substance misuse out before you can engage with us. And I think that's one of the biggest issues, the fact that it's not recognised and it's not supported, where actually, in fact, those issues should be dealt with side by side. And we should, actively work collaboratively together on a joint approach that we can deal with those issues together. Having a dual diagnosis worker to help clients in the recovery means that they've got an advocate, basically. as mentioned, sometimes they face that barrier of, we can't help you with this unless you've dealt with the other issue. So I think having that person who can help and support you on that recovery and advocate for you where you might not be able to, obviously helps with the situation. So the sort of support and treatment that we provide can be care planning, looking at risk assessments, care and liaison. We're also offering brief interventions, so that might be some harm reduction advice, giving some naloxone training or providing naloxone. Obviously, we're also looking at things like detox, so detox assessments, referral to detox units. I myself can also do some prescribing for SMS services, substance misuse services, so that might be monitoring, managing some of our clients to help them get into treatment or help sustain that treatment. We can also do some motivational interviewing. And then obviously the main thing is that liaising between other services and make sure that they're getting the help and support that they need. So it's important that support is in place, open-led, because obviously, treatment and recovery, it's not one size fits all. So what one person might need, another person might not. And I think it's all about that person-centred holistic approach, that we deal with each person in their entirety, and we address those needs to that person. Our partnership with Housing First has been successful on various levels. I think essentially, we've helped to equip the workers with training. We've also supported them in some reflective practice. So obviously they can reflect on their working, which will obviously impact the way that they work with the service users. We've also developed really good pathways into services that weren't there before. So, things like with Achieve and Urban Village in Manchester. And I think it's just getting out there and talking and making those positive sort of relationships with other services. I've got a service user on my caseload at the moment who was engaged with substance misuse services, had spent a prolonged period of time in prison. This had been the first period of time that he had stayed out of prison for a substantial period of time. However, his mental health took a bit of a decline. He had paranoid ideation about the medication that he was taking and decided to self-detox himself off his substance misuse medication and his mental health medication. So I helped support the worker into discussing these things with Achieve, and it was identified that because of where he'd moved to, it would be suitable for me to go out and assess him with the support worker. So with the help of Achieve and the support worker, we went out, I assessed him, and due to the fact that I am a nurse prescriber, I was able to restart him on a prescription, which meant that he wasn't going out committing crimes, because that was the concern, that he'd relapsed and that he'd end up back in prison when he'd done so well to maintain that period outside. We also managed to refer him to the mental health team, and he's due for an assessment, so hopefully he'll be able to sort of get some support around their mental health needs as well. And I feel like if we didn't do that, he'd probably still be sat there, without that help and support, if we hadn't have gone out and done that home visit. I think these pilots and projects are important with people with dual diagnosis because obviously of the stigma, a lot of services don't tend to listen. There's a struggle from that service user as well because they might have had a negative experience in the past. And I think, it's great that they've got somebody, an advocate, who can, sometimes often speak for them because they don't feel comfortable, and it's just having that extra person to support them in what they need and support they need from services. Yes, I would absolutely recommend that other NHS trusts take on board this dual diagnosis pilot. I think it's a really valuable thing that, we have staff with these skills within the services, because I think it's vital that we all understand the needs of patients out there. It's not unique to one particular area. It covers a whole broad range of different services, and I think, the more we empower staff, the better understanding and the better help that service users can get. I would just like to say that I think, this pilot is fantastic. I think it helps those really complex and hard to reach service users that possibly have been forgotten about, who don't have a trust in services. I think it's, genuinely humbling to be a part of their sort of progress from where they were to where they are now, and seeing that we have empowered them, that we have given them sometimes a bit of hope for life, a bit more passion back in them. And I think, that gives me the hope, when I go home, I do think to myself, actually I might have made a little bit of a difference to somebody today, and that's what I do my job for.
That was fantastic there, hearing from Gill, who is clearly so passionate about the work that she does. I'm delighted that not only does Gill overcome many kind of hurdles in supporting people in Greater Manchester using Housing First services, but she's also helped both herself and Adam overcome significant technical barriers in getting on this webinar today. So I'm absolutely delighted next up to introduce Adam Clayton. Adam's from Greater Manchester Mental Health NHS Foundation Trust, and he's going to speak a bit about the involvement of the Foundation Trust in the development of this partnership work with Housing First in Greater Manchester. And then you'll be delighted to know that Gill's going to join us for the panel discussion after that. So welcome, Adam.
Thank you very much. Hello.
Hi, Adam. We can hear you. We can't see you, but that's not a problem. Gwyn will put up the slides. Oh, we can see you. Brilliant. Fantastic. We're off. Thanks, Adam.
Bear with me, and we'll give it a go. So thank you very much for the introduction. So my name is Adam Clayton. I'm the operational manager over Housing First, the GMMH aspect of Housing First within Greater Manchester. And my colleague Gill is here as well. You've just seen a video from. So I'm just going to explain a little bit more about the model, our model within the Housing First aspect, because there's a few different parts to that, and then some of the staffing makeup as well. And then Gill's going to talk a little bit more after that before we get to the questions, but I'll try and keep it to the point. So we are subcontracted as part of this model, and we have within that model a staffing makeup, and we also deliver clinical and a clinical aspect to service users, and then we also look at building capacity within the model from a staff resilience point of view and providing training. So the clinical role that the dual diagnosis workers offer is around assessment to individuals. So they might see a person directly, assess somebody, considering both mental health and substance misuse needs collectively to reduce the need to put somebody through multiple assessments. The role from that point might go on to offer some direct support, or it may be referring people into services and advocating why maybe both mental health and substance misuse services do need to consider somebody's needs at the same time, because that can be quite a barrier for one service suggesting one need needs to be addressed over the other. The additional clinical role that the dual diagnosis workers offer is to the support worker staff within the model, and that's to provide advice and information. So they may work with a worker after they've assessed somebody who's successfully moved into services, and that's to provide the worker with a greater understanding around the specific needs, the support needs, potential relapse indicators for that person, so that they can continue to support that person throughout the rest of their journey with Housing First. The second aspect that we deliver within the model is around the training and the capacity building. So part of that links to that support to the staff in order that they better understand how to work with a particular person for their individual needs. And then we also deliver training to the staff and reflective practice. The training, the core training that we deliver to all staff focuses on trauma-informed services and harm reduction. And then we also have been able to offer some more bespoke training as the needs come up, and we've been able to work together to look at how we can do that. In addition to the training, we then also offer reflective practice, and across the different zones within the GM Housing First model, that the partnership's broken down, so the reflective practice is shared across the zones, so that the different workers in the different zones are able to talk about the individual unique challenges on their caseloads and within the different boroughs of Greater Manchester, because there are intrinsic differences, and it allows to share the learning as well. So our staff deliver that to the wider Housing First support work staff and the team leaders. So just to give you an idea of the operational model itself, so the dual diagnosis workers, we have 4 staff. Each one of those staff will work across the 4 different zones of Housing First. So that's either the centre of Manchester or the 3 borough clusters within the other 3 zones. And as discussed, their roles to think about the clinical delivery, training, reflective practice. In addition to that, for the staff directly, our staff directly, they have access to a clinical psychologist, and that's to provide some reflective practice for them to make sure that they're getting the support that they need to manage their caseloads, and to be able to debrief and go back to doing their job and supporting the support workers around any particular challenges and complexities. And then more recently, we became aware as the pilot's gone on that there's a particular challenge within certain areas, depending on commissioning models, about access to services without diagnostic assessment from a medical perspective. So we've been able to bring on board a psychiatrist who works with the practitioners on specific cases where there are those challenges around needing either an initial diagnostic assessment or further advocacy from a consultant psychiatry background in order to overcome any barriers and access services. And then we've got a wider support, leadership management support, so we can escalate and share information and try and overcome barriers through more of an organisational approach. So that would be myself and then the leadership team above. In order to, just the next slide, in order to evidence the outcomes of this, it's been quite a challenge over the course of the pilotship to make sure that we got the KPIs correct. Initially, they were set up based on more of a substance misuse model, which is driven by people who are actively choosing to engage in a service. And over time, we've realised that whilst that was effective for that direct contact where somebody is asking for help and wanting to be assessed, there was also a need to evidence probably a greater proportion of the work for the caseload where people weren't working directly with our staff. So either we'd successfully supported somebody into services, but we were still supporting the wider partnership staffing team, or maybe somebody didn't want to or didn't necessarily need to be assessed or to work with our practitioners, but the support staff needed some help in understanding that person's needs so that they could continue to do the job effectively that they required. So we've adapted the KPIs as time's gone on, and we've now got a set that allow us to do both objective and subjective reporting, so that we can hopefully evidence progress from the support, whether that be direct contact assessment, which would be what we refer to as pathway 2, or if it's indirect, which is pathway 1. So we can monitor if someone's outcomes are improving, if their engagement's better, if they've been able to remain in attendance at appointments, or generally they're managing other aspects of their life better and communicating and understanding more about their own individual needs. In addition to that, we also just track any sort of bespoke advice and information that's provided as well. The KPIs that we use at the moment allow us to record against physical health, substance use, mental health, social functioning, considering someone's recovery, interventions, and then the overall quality of life. And I think we've only just recently implemented the changes to allow us to do more of the pathway 1 reporting. So we're due to complete the first report on that soon. So we're hopeful that will allow us to do what we've set out to do. I'm just going to hand over to Gill, who's just going to talk a little bit more about, I suppose it's a pilot within a pilot that Martine alluded to in relation to inpatient admission for detox. So I'll just pass over to Gill. She'll talk very briefly about that, and then just a little bit about the impact from feedback we've had.
Hiya. Yeah, so I just wanted to sort of basically have a quick chat really about the pilot that we've got, which is with Housing First for Chapman Barker unit. And basically, it's just about us being able to identify somebody who's in that treatable moment, and basically fast track them into a service that they might be made to sort of jump through hoops otherwise. So obviously, with the support of Housing First, we have identified somebody who's going in next week. So hopefully we'll have good response from that, and we'll be able to update as and when that's completed. So just wanted to mention that because I think it's really valuable part of the project, and I think it's something definitely unique that we're doing. So I just wanted to basically talk about the impact of the project. So obviously having the 4 dual diagnosis practitioners has greatly helped that bridge between Housing First. A bit like I said on my video, really, it's created so much more flow in between the services, because we are that sort of in between with that middleman. We can advocate, we can, we've got those direct links, which makes it easier for us rather than the Housing First workers. Obviously, there's always been that brick door sort of thing for mental health services where nobody can get in, nobody can speak to anybody, no one can contact them. And I think we've definitely had a really big impact on sort of breaking down that brick door, really. And obviously, as dual diagnosis practitioners, we've been able to overcome those barriers, basically working with people who are not under the care of statutory services, and we can explore that harm reduction and basically what support they might want. Thank you.
Thank you very much. I think that kind of covers everything with the video as well. So I think there might be some questions coming up. Sorry about that, and that we're on mobile. I hope it works.
No, that's absolutely fantastic. Thank you so much, Adam and Gill. We're so pleased that you persevered with the technology, because it was a really great addition to Martine's opening presentation. So thank you so much for being here, and this is working absolutely perfectly. Martine, if we could invite you to come back on camera, and we'll take a few of the questions that have been coming in during that session. As I said to Martine earlier, there's been lots of questions about mental health, because I think it's recognised that this is one of the big barriers facing services across Wales and across the UK. So it's been really useful to hear from you all today. So first one, a quick question. Someone's asked if you have any interim reports available on the pilot to demonstrate the positive impact, or I guess if not, whether there's any planned publications that people could learn from in the future.
So the 3 pilots are being independently evaluated, and there are interim publications there, but we don't own that, so we're relying on that when those are published and being shared publicly. However, we have just commissioned a Greater Manchester local evaluation that will take into account the impact of our joint work together, and we've said that that's going to be finished in August, so we'll happily send that over to be shared far and wide.
Oh, brilliant. Thank you, Martine. That's great. A question that's come in from Alex. So have you noticed any instances, any of you really, where the health and housing sectors work differently? So maybe there's different cultures and different systems, and you've had to kind of find solutions to collaborate effectively. Some of the things that we often hear is that mental health services here work in a kind of very different way to homelessness services, and sometimes there's a bit of that culture barrier. So how have you found that, and how have you overcome it?
Did I go first? But I think from our point of view, and I think Martine, correct me wrong, but I'm probably speaking to the wider model with Greater Manchester. Those challenges that you've described are very much alive and kick in within Greater Manchester. And I think part of the complexity for Greater Manchester, I don't know about other areas, different models, but we've got 2 different NHS mental health trusts, and then within the different boroughs, we've got various. It's not.
Sorry, I'm not sure, Adam, if anyone else is having any issues with sound, but you were breaking up a little bit there. Do you want to try again?
Yeah,
that
better. Yeah.
Brilliant. Great, thank you.
We're on a mobile, so it might just be the signal. I do apologise. I was just saying, within Greater Manchester, it's not just the difference between the mental health and treatment services and homelessness. It's the different boroughs within Greater Manchester that have different models of commissioning. There's 2 different mental health trusts. There's various different substance misuse providers. So having the dual diagnosis practitioners within the Housing First model, it does help for that, a degree of understanding about what those complexities are and how to navigate some of that. And we've got the operational structure above as well, where things need to be escalated. But it's definitely a challenge. I don't know, Martine, from the wider delivery.
No, that was what I was going to touch on there, Adam. And one thing that really surprised us when we started off with the programme, I think we naively thought that the dual diagnosis practitioners would be able to just navigate those different health systems and substance misuse systems beautifully, because it was, maybe magic knowledge within the sector. And it soon became apparent, didn't it, that we were all facing exactly the same barriers. And one of the things, I mean, we talked, didn't we, briefly about we've changed things right from day one, but having that clinical psychiatrist offer that Adam mentioned has helped with some of that, hasn't it? Because we can get some diagnosis and treatment plans there to help navigate some of those barriers.
Thanks very much, Martine. I guess you made reference to it, I think, from the start, that the Mental Health Trust was involved right from the start, rather than being, a relationship that kind of got added on or developed further down the line. How critical do you think that was, Martine, for making sure that, mental health was there from the very, very start, in terms of access for people using Housing First?
Yeah, absolutely vital. Because, first of all, we were able to shape that offer together based upon, both sides' expertise, I guess, and as I mentioned as well, the feedback from people with lived experience who'd faced things. So we were on the journey together from day one in terms of that learning, shaping the offer, embedded within the teams, and the delivery teams have really appreciated that. It's made a massive difference to the work that they do, and of course to the people on the programme. And I think the approach has worked well in the fact that it is embedded and has been from day one, rather than as I said, it being seen as a bit of an additional service or a bolt-on service. We want partnership, aren't we? And it works well.
And I guess for Adam and Gill, I guess that means that you feel like a meaningful partner right from the start, rather than a kind of afterthought and just fit in with our systems. Because if you're around the table from the very beginning, you're able to shape how the project moves forward.
Absolutely, and we understand what the project's about. We understand the values, and we understand the challenges and what Housing First is trying to achieve. So we're not trying to understand that and then navigate various different options and routes into. We're having those discussions. We're on board, and then we're able to advocate effectively for the people who are using Housing First and for the wider department as well.
Definitely. Thanks, Adam. We've had a comment from Hannah in the audience. I haven't got any questions as such, but just wanted to say how impressive this work is. Well done.
Thank you.
A question I was going to ask to Gill and maybe see reflections from all of you. So, Gill, you talked about some of the stigma and the services having let people down in the past, and then that reflection on sometimes it's been difficult for people with that dual diagnosis to kind of get access to services because they're told, oh, you need to go sort out your substance use before you can access the mental health. So how have you kind of worked with services to try and improve those cultural attitudes towards people, to try and reduce that happening?
I think it's.
Sorry, Gill, could you just turn the phone towards you a little bit, just so that we get a bit better audio? Thank you.
Is that better?
Brilliant.
I was just saying, I think the key is communication, really, about getting out there. It's getting into those services and basically making yourself known, so inviting yourself to those team meetings, getting key contact people who you can speak to. And then I think it's, you know, like, especially when you've got a service user, you can just go direct to somebody. It's not just having to go through reception, you know, it's not having to go through all those normal pathways. You know, it's about building those positive relationships with the services. And it has been hard, you know, and it kind of feels like it's only just kind of coming together now. You know, we've worked really hard over the past 2 years, and I think we're only just getting to a point where we're sort of starting to see some positive outcomes for our people as well. And I think equally, I think one good point, you know, with the 4 of us, we've all got different skills, you know, so we're all from different areas and backgrounds. So mine is substance misuse. We've got somebody who's from criminal justice, we've got someone from mental health, and then we've got someone who's really good at safeguarding. So we've got a really, really good skills mix where we can all sort of discuss and talk between the 4 of us, and we back those ideas off between each other, and then basically get the best outcome for what we need.
Brilliant. And we've had a question from Simon, and I'm not sure, Gill, whether this again might be one that's good for you. But from time to time, hear about the difficulty of accessing services, particularly when intoxicated. So, what are the kind of challenges of working with people who may at times be intoxicated, and how do you kind of deal with that?
I think because my background is substance misuse, you know, I'm not going to away from that. So I think for me, it's about, you know, helping other services realise that just because somebody's intoxicated doesn't necessarily mean they can't have an assessment. Obviously, there is a point where that can't happen, but I think all too often they're kind of brushed away because, oh, they're intoxicated, they can't have a rational thought, they can't rationally think. But that's not true. It's about education to other services about what we can do. But equally as well, you know, to the service users, you know, it's about having those open conversations with them and saying, you know, look, if you want help, you can't turn up, you know, when you are heavily intoxicated. So it kind of works both ways, really. It's about education for everybody, and I think that's a really vital role that we play within the project.
Yeah, thanks, Gill. I think, you know, that comes across really clearly. It's really interesting. We were reflecting earlier on, you know, is it best to kind of buy in mental health and substance misuse specialisms as part of a kind of integrated Housing First team, or should we really be able to access generic NHS? You know, we shouldn't have to be buying in, like we should be able to help people to access. But actually, it kind of sounds like the way that you guys work is kind of a bit of both, actually, in that you've got people in-house who are able to do that very immediate, person-centred, trauma-informed care at the right time. But those, you know, yourself, Gill, and others are also advocates for getting people through the doors to other parts of the system in a much, much quicker way.
And I think I totally agree with everything you said there. And I think what we're able to do by being intrinsically part of Housing First, but also part of GMMH as an NHS trust that's delivering services across that area, is we're able to shift the policy and the approach to working with people who are homeless and who have dual diagnosis needs, in order that the organisation starts to change, the culture changes. And so within the different boroughs where we deliver services as an NHS trust, we've got dual diagnosis networks set up now. So substance misuse, mental health treatment services are working together to think about how they can offer assessments collaboratively, and we can advocate in relation to homelessness, trauma-informed care. So we can take a whole system approach within the NHS aspect of our role, whilst then taking that back through and advocating on the Housing First side as well.
That's really, really interesting. I think that's given people a lot of insight there, how it doesn't have to be an either or, it can be that really powerful combination of the two. I hope Gareth is making some notes from Cymorth, who's doing some research on this at the moment. Someone's asked whether there are any established mechanisms for diverting mental health funding to Housing First. That, you know, because I'm not sure how your project is funded. It's pilot funding, isn't it? But do you foresee maybe in the future there being a kind of combination of homelessness funding, but also some mental health funding, recognising that this is as much of a health issue as it is a homelessness issue?
That's our absolute approach. We have conversations locally within Greater Manchester because, you know, it is a health approach, criminal justice approach. We know, we know the impacts far and wide, and equally, we're doing some work at the moment to try and campaign for an extension to the pilots. And, you know, our ask there is that it isn't just a homelessness, it isn't just looked at in isolation with housing and homelessness, that it is viewed for funding from other pots. So, we've not had any firm news with any of that yet, but that is our ask.
Fantastic. A question from Lynn. Have there been any issues from housing providers buying into this model? So things like accepting and not evicting clients who are at the harm reduction stage of support, so people who are still actively using. How's that relationship been with some of the housing providers in the area, and how open have they been to that harm reduction approach?
So we're really lucky again in Greater Manchester. As I mentioned before, we'd had the 3-year social impact on prior to Housing First. And I think that had been a real culture shock for some of the accommodation providers initially. But then we're now 5 years into that work with Housing First. And I've got to say, we've got an amazing group of registered providers within Greater Manchester. We have the Greater Manchester Housing Providers Network, who all endorse the Housing First programme. They regularly attend training that I talked about. We've got a good practice charter that's been really effective, and we facilitate a monthly forum where the housing officers or neighbourhood officers, whatever they are in each organisation, come together with the Housing First workers and talk about barriers and good practice and share that. And they're really well attended from both sides, and everybody gets a lot of value from that. And then equally, we've not got many KPIs in our Housing First programme, but one of the ones that we put in from day one, again with our delivery partners, was that the Housing First workers needed to make a weekly contact with the accommodation provider. And that has worked incredibly well because they've got such good relationships now, and things are just nipped in the bud really quickly. So that is one area where we have probably got quite a lot of information and documents that we'd be more than happy to share if anybody's interested.
Oh, fantastic. Thank you so much, Martine. That sounds fantastic. And there's a real sense of partnership in every element that you've talked about in this project. There is that true sense of partnership and working alongside people to understand barriers and to overcome them together. And I guess, you know, one of the things that we're interested in, I guess, is trying to get beyond a group of passionate individuals who make stuff happen and try and get things much more embedded within the system and the structures. And I guess, you know, it sounds like you're well on the way to kind of doing that. Obviously, there's probably lots of challenges ahead, but it does sound like you're making some real progress there. And that's probably all credit to your passion, your approach to collaborative working across the two organisations. It's been absolutely fantastic. I feel like we could be here for hours talking about this, and I know it's something that everyone in attendance today, we've got 80 people on this session who are so interested in this. I'd like to say a huge thank you to you. I know you're really busy, all of you, and you know, particularly Gill, who's out there kind of, you know, delivering every day some of the most kind of challenging work out there, but obviously the most rewarding work as well. But I just think it's been a fantastic session hearing from you all. I know there's a lot that people will have taken away. Thank you so much for visiting us from Manchester. It's been an absolute pleasure having you here today. Thank you.
Thank you for having us.
No problem. So we'll take a break till our next section now. So we'll take a 10-minute break and we'll see you at 2:35. Thanks, everyone. Bye.